this. One sec. All right. And that's you guys. All right. Can everyone see that so far?
Yes.
Yes.
Perfect. All right. Present. One sec. Let's see if it's going. All right. All right, so just a quick introduction about me. Like Thomas said, I'm a certified functional manual therapist. Been practicing for about 9 years, 5 of which have been in Peconic Bay. I work closely alongside all the sports medicine orthopedic doctors out there that are part of our concussion program. We work right across the hallway, so it's kind of a unique situation where we all bounce ideas off each other between Dr. Olajimi, Dr. Viaz, Dr. Cespedes. And it's a nice little interrelationship we have out at Peconic because we are in constant communication with each other. And I also, aside from working as a physical therapist out there, I also am a teaching assistant for Stony Brook Physical Therapy's orthopedic program and their kinesiology program. All right, so to jump into my talk, the goal I wanted to present to everyone is kind of a clear and concise way to differential diagnose any of our patients that are coming in with concussions, anything else that may occur when they come in during a physical therapy evaluation, OT evaluation, or any of the doctor's evaluations. So to begin, I'd like to talk about operational definitions. So if you think about dizziness, a lot of people confuse dizziness and vertigo. So what I like to outline here is that dizziness, for a patient standpoint, can be described as an internal feeling of being lightheaded or faint. Vertigo is that feeling of the outside world spinning or moving. They could last for hours, seconds, minutes. And then imbalance is a sensation of unsteadiness and may include a history of falls. Obviously, a lot of our concussion patients will present with dizziness after concussion. They don't always do it, but it's good to know that we distinguish between dizziness, vertigo, and imbalance. And then those are my little guys. Okay, so we all know what a concussion is, but I want to highlight some of the things that might interrelate a concussion with a vestibular problem. So the metabolic cascade is important. The axonal injury, the blood flow changes, all these things can affect both our concussion patients, but also the vertigo symptoms that may present depending on the patient. We've known over the years that the concussion definition has evolved from being grading scales based on loss of consciousness to now our more current definition and symptom-based classification. So what I want to say is that while we have the concussions, and it could be more cortical involvement, you also have to think about with the impact, there could be a labyrinthine concussion, which could cause immediate vertigo, immediate disequilibrium, immediate cognitive problems. So the key to our patients is making sure they're all an N of 1. So we have to identify the underlying cause of the possible symptoms. So not every patient's going to have a headache. Not every patient's going to have blurry vision, inability to concentrate. But we want to make sure that we're talking to the patient to get their subjective history. Does any of these deficits, have they been there before the concussion, like a migraine? Because that'll guide our treatment approach on how we attack the evaluation and how we guide our rehabilitation process, especially in the physical therapy, occupational therapy settings, and how our primary referrers refer to us. Okay, so the main differential diagnoses that are common, this is not an exhaustive list, but it's good just to have an idea of what they are. BPPV, vertigo, peripheral vestibular dysfunction, central vestibular dysfunction, vestibular migraines. It could be a cranial nerve 80 involvement. It could be a psychosomatic dysfunction, and then other sequelae I'll list later to talk about. The most common cause for us that we see would be BPPV and dizziness. We have to remember that a lot of the research on concussion is generated in the sports population, but we also do see a lot of elderly patients or weekend warriors. They'll fall playing pickleball or something, and they could bang their head on a cabinet, and then they wind up with concussion. So we have to be aware that not everything is sports related with differential diagnoses. 50% of people over the age of 70 will experience BPPV. The other things that could also affect BPV are cardiovascular disease, diabetes, head trauma, like we said, migraine, stroke, TIA. So we have to be able to differentially diagnose what is the actual root cause of what we're seeing when they present into our physical therapy evaluations. All right, so we'll jump into BPP first. All right, so benign paroxysmal positional vertigo, as we know as BPPV, following concussion, 77 to 22% occurrence. It's more of a mechanical dysfunction, oftentimes bilateral following a concussion just because of the nature of the impact. Posterior semicircular canal is most affected, and oftentimes with benign paroxysmal BPPV, the nystagmus will fatigue because it's more of a peripheral problem. So what we see in the PT setting when we're evaluation using the Hall-Pike-Dix test, you might see a rotary torsional nystagmus that if it's more of the posterior semicircular canal. So that's the one we most commonly see. So that's the one I'm going to stick with talking about for now. They'll talk about the room is spinning with changes in head position. That's why it's the positional vertigo as opposed to just true vertigo. And what happens is, most of you probably know, the otoliths from the utricle are displaced into semicircular canals, causing an imbalance, and that's what we often see as a presentation, that they will come in with the feeling the changes in position, whether there could be tilting their head back to brush their teeth, laying on their side is the most common one. If someone presents on an evaluation and they're saying they're laying on their side following concussion, and all of a sudden they say the room starts spinning like crazy, then that means that we should check for BPPV. Okay, so then what we're going to talk about now is the difference between BPP and vertigo. Vertigo is obviously peripheral vestibular damage. It's an abnormal firing rate between two of the ears at rest. And because the firing rate is changing, the perception of movement when there is no movement occurs. So what you see is, as a peripheral problem, you'll see the nystagmus is beating in one direction. So the fast phase is only in one direction. They'll still have that spinning sensation, but it could be at rest. And the balance deficits will present. So we just have to make sure that while we're evaluating concussion, some of the concussion symptoms that a patient may be complaining of could be related to vertigo, could be related to BPPV. Okay, so BPPV and vertigo are peripheral vestibular dysfunctions. So let's just talk about their clinical presentations that could present to us in the physical therapy evaluation. So we know that their nystagmuses are usually unidirectional, not always, but 99% of the time they're unidirectional. When the patient will focus on a target, the nystagmus will suppress and fixate. And then when you're looking towards the direction of the fast phase, this nystagmus will increase speed. And the fast phase is the direction of the intact ear. So and that's Alexander's law. So if it increases speed towards looking towards the fast phase side, so if it's fast phase to the right and you look towards that side, it'll get stronger. And then when you look away towards the weaker side, the right ear, then that will diminish the speed of the nystagmus. Some peripheral diagnoses that we see often are Meniere's disease and acute unilateral vestibulopathy. So Meniere's disease is common because it can happen after a head injury because endolith can build up. The classic presentation with someone without a concussion that you might hear is they always complain of ear fullness, tinnitus, the ringing in the ears, temporary hearing loss, and then there's 2 or more episodes of vertigos that last 20 minutes each. And it's the whole process of Meniere's disease, to the current understanding, is it's a decreased regulation of the endolith fluid. So there's a buildup of fluid, it's not moving properly. So what happens is these presentations occur because of that. And another name for it is called endolymphatic hydrops, if you hear that term. Okay, so the newer term, acute unilateral vestibulopathy, the newer research by Strupp et al. Has classified this as a new term that is synonymous with vestibular neuritis. So what happens with this? It's acute onset of sustained vertigo, usually lasting more than 24 hours. Sudden onset in a peripheral nystagmus. There's no central neurological signs or symptoms. So if you have central neurological signs or symptoms outside of, let's say, a red flag, that it wouldn't be acute unilateral vestibulopathy. There's no evidence of VOR away from the fast phase of the nystagmus, and no hearing loss or ear pain, and no other diagnosis can be accounted for. There's other inflammatory conditions like labyrinthitis that could be related to this, but if it meets more of this criteria, they're currently calling it acute unilateral vestibulopathy. And that's key too, because some of these symptoms, like we said, could present as cortical concussion, or it could be related to a stroke. So we have to be able to, in our evaluations, determine whether we have to refer out or continue our treatment plan. And usually by the time they get to physical therapy, we're on a good track, but on the off chance we need to refer out again to neurology, we will. So then that brings into me talking about central vestibular function. These are ones we have to just be aware of and make sure there's nothing seriously going on. So the clinical presentation is nystagmus is constantly changing direction. So a patient will look right and the nystagmus will be there. They'll look left and the fast phase of the nystagmus will change directions. It does not suppress with visual fixation, and it can be upbeating. There'll be other neurological signs and symptoms, and there will be dizziness. The nystagmus, often with central vestibular dysfunction, does not fatigue. So this is important too for us, that if we're treating someone with concussion and they have a past medical history of a congenital head injury or a congenital defect in their brain, that some of this stuff may present. So we have to be aware of their past history so that we don't over-refer out unless we see other signs that may indicate a stroke, anything that might be important to refer out to. So central vestibular dysfunction, as we probably know, arises from brainstem lesion or cerebellar degeneration. Common diagnoses that could be associated with this are vestibular migraine, stroke, and multiple sclerosis. So we'll talk about a couple of those. Before I jump into the common diagnosis, it's always good to know how to screen for a possible central nervous system involvement. So one of the gold standards is using the HINTS exam for checking for acute vestibulopathy. So in order to do the HINTS exam, you want to make sure that they have persistent signs of dizziness and nystagmus present before you do the test, because if there's any type of central nervous system problems, you want to make sure you refer out immediately. Don't even do the exam. So the HINTS exam, the head impulse nystagmus test of skew. So what you want to check for is the head impulse test. If it's positive, there will be a catch-up saccade when you're using the head impulse test. So that's one of the check marks for checking for a peripheral problem. You want to make sure the nystagmus does not change direction, because that indicates the peripheral problem. If the nystagmus changes direction, depending on you're looking right and left, there we're thinking more central issue. You do not have the vertical test of skew. So the test of skew is you're going to cover one eye and then quickly cover the other eye with the other hand, and you're looking for any deviation of the eye. If there's a deviation, that's more indicative of a central nervous problem, and dizziness is present. So that's a good way to remember the HINTS exam to check for peripheral problem. If you have an infarct, that's my little diagram on the right, the head impulse test is normal. The fast phase of the nystagmus is alternating. And under the test of skew, the eye will refixate once you uncover it to the point of where you want them to focus on your nose. So that is showing that there could be an infarct, and usually it's in the posterior circulation infarct. So we want to make sure we refer out immediately, just in case something's going on. Okay, so then that leads to my other talk about the vestibular migraines. This can be common in concussions. Just the regular type of vestibular migraine, most common in women more than men. It's usually found to have an autonomic, inflammatory, and connective tissue components. So when we treat these patients, it's important to know if they do present with this type of symptom, we will make sure we remember if the origin was pre or post concussion, and if it's post concussion, we make sure that we treat it appropriately. So then we want the clinical presentation may or may not have headaches at the same time as a vestibular migraine. They're going to have sensitivity to light and smell, throbbing on one side of the head. They're going to have episodes of vertigo and unsteadiness on their feet. Okay, another involvement that is key to talk about is cranial nerve 8 because of the vestibular component of cranial nerve 8. Let's see. So with the impact from a concussion, the cranial nerve 8 can be disrupted. So what will present clinically is decreased balance, sensorineural hearing loss, balance deficits, and vertigo. The vestibular portion of the nerve, what happens is when your head turns to one side, your fluid inside your vestibular organ shifts, moving the sensory cells inside. The shift creates a signal about your body's position of movement. So if any of that's damaged, you're going to get the balance deficits, the vertigo. So that can happen with any of the impact that we see with our concussion patients. Okay. And we have to always make sure to talk about the psychosomatic component of our concussion patients because it's a growing population that we have with us. Concussions can trigger chronic stress, anxiety, depression, personality disorders, and these type of disorders can present with dizziness, vertigo, decreased balance. So we want to make sure we're asking our patients, do they have a prior history of any of these disorders? When they had onset of anxiety or depression or chronic stress, did you get dizzy or vertigo, or is it after the concussion and this started occurring? We want to make sure that the newer treatment approach is trying to get patients to cognitive behavioral therapy if we can do it. And we want to treat any of the underlying components like that. Okay. So then sequelae that I like to talk about, most of our patients, not always, but they have some sort of cervical component to the concussion. So if they're having radiculopathy, tinnitus with cervical spine movement, visual disturbance with neck movement, and disequilibrium, that's where the PTs come in handy because we can treat this type of symptom if it presents to make sure that the symptoms are held at bay. Another thing to talk about is vertebral basal insufficiency. We want to always make sure as PTs and other providers, we screen out VBI insufficiency. So the older research was to put the patient into provocative positions of end range, passive range of motion, into extension and cervical rotation. The newer research is showing to more screen out based on a subjective history from the patient and also doing an active range of motion seated into extension and rotation just to make sure we're not holding in end range positions and desiccating things we don't need to. Just a reminder, the 5Ds and 3Ns just to look out for if they pop up on our concussion evaluations. Diplopia, dysarthria, dysphagia, and drop attacks. And then the 3Ns would be nausea, numbness, and nystagmus. So if you see any of those, think about referring out along with the position that might cause that problem into active range of motion. And then talking about continued research like Dr. Spini's been talked about on the TV, chronic traumatic encephalopathy and depression. One of the research articles that's more of a case series that I've been finding about young athletes exposed to repetitive head impacts. There was the case series showed that young brain donors exposed to repetitive head impacts were highly symptomatic regardless of the CTE status, and the cause of symptoms in the sample are likely multifactorial. So we need to have future studies on young brain donors unexposed to repetitive head traumas to see to clarify the association between concussion symptoms, white matter, microvascular pathological findings, and their clinical signs and symptoms. And then depression is another risk that we see, obviously. So there's newer research with that. One of the newer articles I found, according to Lambert and others in their systematic review and meta-analysis, there's an association between persistent concussion symptoms and depression. So about 4.56 likelihood ratio of this occurring with a 95% confidence interval. They agree that there needs to be further research on the variables that will improve long-term outcomes with our patients and decrease adverse symptoms like depression for us to treat so we can help them not have as much depression. So obviously we're all here, so we all know that treating concussions is a team approach and also with the vestibular patients, so we have to all be in constant communication with each other. So the concussion providers refer to physical therapy, vision therapy with OT. I always refer back for the vestibular patients to either the ENTs or the neurologist if something's presenting weird. The neuropsychologists are key for the cognitive behavioral approach, so we refer to them. It's nice to know that Dr. Olson is near us in Mather from the Peconic Bay group, because now I have someone to refer to, because I think we don't have one out there currently that I know of. But it's always important to be in constant communication with your team, so that if we have to brainstorm ways around certain presentations that we're not sure of, that we work together to help the patient achieve their maximum potential. Okay, so this slide, we're going to jump into the vestibular rehab therapy. So these are patient pictures I took with my student recently. So we're lucky enough out of Peconic Bay to have the vestibular first goggles. So they allow us to see if there's any nystagmus present that our eyes might not catch in just the daylight type of time. So vestibular rehab therapy uses concepts of adaptation, habituation, substitution, and cognition to reset or return a patient's function. So with adaptation, our goal is designed to enhance the patient's visual ocular reflex through central compensation, neuroplasticity, and symptom provocation. So this can happen to 1 to 2 minutes. We can help them if it's targeted correctly. We do adaptation. We can test it through the visual acuity test. If there's obviously a 2-line difference from static, shows there's a vestibular type of dysfunction. The other key concept is habituation. So with habituation, repeated exposure to provocative stimulus results in reduction of the pathological response. So while we're treating concussion vestibular patients, their physical therapy, OT therapy treatments will mimic each other, because we want to try to restore that patient to their baseline function without it. So habituation, usually an example would be symptom provocation with a busy background, or we can use an optokinetic stimulus on an iPad to have the patient repetitive exposure to stimulus that might trigger them, like a moving background when you're driving, and then that'll help reduce the pathological response. It's important to note that habituation and adaptation usually occur together in the treatment programs. And then we're going to talk about substitution. So substitution is trying to strengthen the weakened system by challenging the remaining ones. So this is where we target the vision, vestibular, and somatosensory systems. If the vestibular system's missing or impaired, we're going to challenge the vision and somatosensory systems to try to help them the weaker system become strong. All right. And then moving on to the continuation. This is a chart I took from the American Institute of Balance. It's something I use for my treatment all the time, to have in the back of my mind. So it's just an outline of the symptoms, the clinical findings you might see, the conditions that could be associated with it, and then just a general guideline of treatment and how you can attack the patient. So say we talked about blurred vision or double vision. So they're obviously going to have a decreased visual acuity test, so they can have oscillopsia, abnormal VOR. So you want to use adaptation principle to help stabilize their gaze and change the velocities to help promote everything. And then you can use substitution to restore any of the other vestibular functions. Good. So this is a quick thing about BPPV. If those of you are present that treat it, I just kind of did a modified epimover quick run through, because it just helps to remember. Sometimes you forget if you don't do it often. So this is for strictly treating the posterior semicircular canal, since it's the most common one. So when you're doing it, you can have the patient long sitting, turn the patient's ear to the affected side. You're going to lay back quickly with your head slightly in extension while you're supporting them. Hold the patient down until a sense of spitting stops or the nystagmus stops. Usually I wait a minute, because if you bring them up too early, even if they say the symptoms stop, you might get the crystal stuck in one position. So you got to try to avoid that. Otherwise, the patient won't be happy. So then you're going to turn the head to the affected side, roll onto the patient's unaffected side, keeping the head looking towards the floor, and then you quickly sit up. So we have to make sure it's done quickly, but waiting till those symptoms resolve, so that the crystals have time to settle into the proper position. And then my specialty as a certified functional massotherapist is with cranial sacral therapy and mobilization. So the newer research, and it's still being worked on, is supporting the use of soft tissue mobilization, craniosacral therapy, and postural stability to help our patients. We want to still do more clinical research to understand the mechanisms of why therapy does help, but the current theory is that the musculoskeletal compression from the soft tissues and the fascial systems could impact the flow of lymphatic fluid. And by using manual therapy and cranial mobilizations and soft tissue mobilizations around the head and in the areas of impact, that can release some of the lymphatic fluid and help the healing process occur. And it always helps with the cervical dizziness and radiculopathy too if the patient presents like that. And these are my references. And does anyone have any questions?